Hello, good morning. Good morning, thank you. Good morning. Welcome, everyone, to this really special event. This is an event called Behavioral Health Care Under Pressure in Massachusetts, Policy Solutions for a Sustainable Workforce. I'm really glad that everyone is here this morning. Thank you for being here, and thank you for everyone who is joining online as well for tuning into this special event and conversation. We're starting a little bit late for those of you who are tuning in because there's just such a great energy in this room, and I think a lot of people here are reconnecting and discussing and sharing ideas, and it's just really such a great opportunity to be able to connect and collaborate, and I think that's just such a hallmark of this particular community and these particular conversations is how much we want to connect and work together on finding solutions. I'm David Seltz. I'm the Executive Director of the Massachusetts Health Policy Commission. I think many of you are very familiar with the Health Policy Commission and our mission. We were established as an independent state agency all the way back in 2012, charged with monitoring healthcare cost trends and promoting healthcare affordability for all the residents of the Commonwealth. And I would say behavioral healthcare has always been a really core part of our mission at the HPC. In our statute, when it laid out the particular board members that would govern and guide the work of the HPC, it very explicitly called for that one of those board members should have a demonstrated expertise in behavioral healthcare. And of course, saying that in statute is one thing, but then having a person there who will advocate and make sure that that becomes a reality is a whole other thing. And Governor Deval Patrick at the time appointed the perfect person to make sure that that became a reality in Mary Lou Sudders, who was the first appointee as the behavioral health care expert to the HPC board. She would then go on to serve as the ex officio member as Secretary of Health and Human Services for 8 years on the HPC board. But I remember those very early days when the HPC was first getting started and we were a small but mighty staff of less than 10 people working out of the China Trade Center in Chinatown with loaned office space from our friends at the Division of Healthcare Finance and Policy, or CHIA at the time. And Madam Secretary Mary Lou would come and I guess huddle with Colleen and I in our office. Plotting and scheming maybe isn't the right word, but she would was working with us to make sure that the work of the HPC and with behavioral health, that it was not going to be an afterthought, that it wasn't going to be something that was just going to be tacked on to the work afterwards, that it was going to be something that was going to be core to the work of the HPC. And I think that's is an ethos that has stuck with the HPC for this entire time period, and I think it was really important that that was established really early on. And I think it's something that is an ethos that I think all of us in this room hold really deeply when we think about the healthcare system, is that behavioral health should not be an afterthought, that it needs to be core to every conversation that we have about healthcare and about our healthcare system and how we can improve and make a healthcare system that works for everyone. When I think about the work of the HPC over this last 13 years, we have made that commitment into behavioral health in many different ways. I think about our investment programs and how much of our focus has been on behavioral health care and investing in behavioral health care. We had these incredible investment programs at the beginning that we called our CHART program that invested in community hospitals, tens of millions of dollars in community hospitals. Many of those initiatives were really focused on expanding and enhancing behavioral health care services. Community hospitals, but I think we also made a really intentional focus on making sure that those community hospitals were partnering with trusted behavioral health care providers that were already in the community, and thinking about how we can extend those services out into the community. We had a really, I often think about this program that we helped support in North Central Massachusetts that was a school-based telebehavioral healthcare program, which allowed the students and teens at the middle school and high school to be able to access behavioral healthcare services at that school. and how impactful that was, but also remember feeling so daunted by the fact that there was an incredible waiting list for those services, for those teens to be able to access those services. We also did a couple of really impactful programs with our partners at DPH, thinking about the opioid epidemic and substance use disorders, specifically thinking about the impacts on newborns and on children and on families. And most recently, we've been thinking about behavioral health in more of our research space, and did a report a few years ago that was really looking at the behavioral healthcare workforce and really the impacts of this workforce in a post-COVID environment and how that had really strained this particular workforce. And we did kind of a deep dive in trying to understand what this meant and what this meant for the future and what it meant in terms of a policy response and how we might need to continue to make investments if we're going to have a strong behavioral healthcare workforce moving forward. So it was, I think, in light of all of this history and in light of this more recent focus on the behavioral healthcare workforce, it was a perfect timing in late 2024 when the Executive Office of Health and Human Services came to us to discuss this opportunity to establish a new behavioral healthcare workforce center. And we jumped at this opportunity. We saw that this could be something really special for Massachusetts, and we wanted to be a part of it. And so there was some funding that had been kind of set aside by the legislature, and in partnership with EOHHS, we committed to establishing the Commonwealth's Behavioral Healthcare Workforce Center within the HPC. And the goal of this center is to really be a hub, a dedicated hub to conduct research and to make informed policy recommendations, as we do in all of our work, but really with this intentional focus on the behavioral health workforce. There are these behavioral health care workforce centers in many other states. There's actually a network of behavioral health care workforce centers across the country, and we're now a proud member of this network representing Massachusetts. And this team has been hard at work over the past now year and a half to begin the work of the center and our legislative charge in terms of some particular studies, which you're going to hear about today. So it was this perfect opportunity to create this new center and this new partnership. And then we had the perfect fit to lead the center in Amy Doyle. So we found the perfect leader for this work, who brings so much smarts, experience, passion, and a commitment to collaboration. I talked about collaboration at the beginning of this because I think it's so important in this work. It's not only collaboration across government agencies, because there are so many government agencies that this work touches, especially when we're thinking about behavioral healthcare workforce, but it's also collaboration with everyone in this room, because there's a broad spectrum of what we're talking about here. And she's just had this incredible commitment to saying, I want to really make a commitment to going out and listening and creating an advisory committee that can really help guide this work. And that's a really critical part of this work of the center, was creating this Behavioral Healthcare Workforce Center Advisory Group. And many of you are in the room today, and I really want to thank you for your engagement and membership and commitment to this. You've given a lot of your time and energy to Zoom meetings, Zoom breakout meetings, giving counsel and advice offline to Amy and her team. That advice and counsel is so valuable to making this work real and important. I also want to acknowledge a few of the other champions of this work who are here today. Representative Minnie Dome, Undersecretary for Health and Human Services, Amy Rosenthal, who we'll hear from in just a minute. Joanne Marchese, who has been a real champion for us at the Executive Office, along with her colleague and our colleague and friend, Patricia Yu. HPC Chair Deb DeVoe, our proud following member of behavioral health workforce, or behavioral health expert, Marty Cohen, the DOI Commissioner Mike Caljo, and of course I already mentioned our dear friend Mary Lou Sutters, former Health and Human Service Secretary. So this is a big week for us to have this event. This is really kind of a kickoff event for the Workforce Center. We also released our first publication, which you're going to hear about today, and some of the results from this publication. I won't jump too much on the results from this report, but I will just share that one of the main takeaways is that we need to continue to invest in and reform reimbursement for behavioral health care, for our behavioral health care workforce. I think the good news with this is that we do have a strong foundation to work from. This Commonwealth has a blueprint that we committed to over the last few years. It's called the Behavioral Health Roadmap. And through that roadmap that was put forth in the past administration and continued in this administration, there has been an incredible investment in behavioral health care services. That investment has gone in the way of a behavioral health helpline and the establishment of these community behavioral health care centers, which have made a tremendous impact in terms of providing another access point for patients in distress. That has had a measurable impact as Undersecretary of Health Mike Levine talked about an event I was at yesterday in terms of ED boarding rates. We can see that in the data. But we need to be able to sustain our commitment to that roadmap. And that's part of our recommendations today, is sustaining that commitment, sustaining that investment, and also making sure that the commercial payers and the commercial market are also part of that commitment and participating equally and fully along with the state in terms of commitment to the behavioral health care workforce. And I know that when we talk about investment in healthcare at a time when we're also talking about the need to focus on affordability, that there is a tension there. I believe that we can do both. I know that there are so many small businesses, individuals, and families who are struggling with the total cost of care. And that at the same time, we are recommending in this report and recommending in the Primary Care Task Force that we need to invest in these high-value services that are being delivered by this highly effective workforce. And there will some who will say that we have to choose one or the other. And I would say that is a false choice. We spend $80 billion a year in healthcare in Massachusetts. There are inefficiencies. There are ways to shift the dollars into the things that we care about. We spend 7 cents of every dollar on primary care, and we spend about 7.8 cents of every dollar on behavioral health care. We can shift dollars into these areas that we care about without raising total cost of care. It's a matter of values, it's a matter of priorities, and it's a matter of will. So, I think now is the time to act. There is an urgency to build the system that we want, the system for the future, the system that will provide better care at a lower cost for all residents of the Commonwealth. So I hope today that this conversation will galvanize us to that mission and to inspire us to work together to help achieve it. I know one person who is working very hard thinking about all of these dynamics and is an incredible leader, our dear friend, the Undersecretary of Health, Amy Rosenthal, who is, as I said, such a great partner in all of this work. The Executive Office of Health and Human Services, without them, we would not have this Behavioral Health Workforce Center. And so I'm excited to introduce Amy Rosenthal to kick off today's events and provide a few opening remarks. I think we all know Amy. She came from Healthcare for All. She is a passionate advocate for all the things that we care about and is now working in state government, and we are so happy to have her here. She is, in addition to working on so many different things in state government, is the governor's real point person and leader on this healthcare affordability work group. which we all hope, I think, and know is going to lead to some really important change. So thank you, Amy, and I look forward to a few words from you.
Hi, everyone. Yes, the last time I was here, I was testifying at cost trends from Healthcare for All. So thank you. I'm really happy to be here to help kick off the HPC and EOHHS's Behavioral Health Workforce Center's inaugural event. This workforce, as we heard, was established at HPC in partnership with the Executive Office of Health and Human Services in September 2024. We're thrilled to have this partnership with HPC, such a trusted agency. With support from the legislature in the FY23 budget, we were able to get together and create this workforce center because we found ourselves on the verge of a behavioral health crisis in Massachusetts. The need for behavioral health care services is continuing to rise amongst our residents. In 2025, CHIA found that over 20% of Massachusetts residents use behavioral health services. Alongside the challenge of meeting increasing need, organizations report workforce issues that I'm sure everyone in this room knows about, like with staffing vacancies, as well as issues around recruitment and retention. And since 2020, multiple inpatient psychiatric facilities and intensive outpatient programs have closed. We know the inevitable outcomes when people cannot get the care they need in the most appropriate setting for them. They may end up with an increased acuity of their condition, or some may seek care in places like our emergency departments when they would be better served in community settings. Helping patients at the right time get the right care in the right place is, as David was talking about, one of the key pillars of the work group that the governor has created, the Healthcare Affordability Working Group, which we announced earlier this year. And actually, under the leadership of David Seltz, we're looking at this area of work in particular. And the reason we're looking at this issue is that we know it can increase the costs of care, compound hospital capacity problems, and it challenges most of all our patients who need that support. The HPC found in 2024 that 1 in 3 patients seeking behavioral health care spent over 12 hours in the emergency department awaiting further treatment. And I think all of us know that that is probably one of the least conducive environments for people who are dealing with a behavioral health issue. So when people have difficulty accessing this care, sometimes they also forgo care altogether. And CHIA found that 10% of our residents reported doing that in the last year. I'm very proud that the Healey Driscoll administration has committed to behavioral health care access for our residents as a priority. And we're working to make enormous strides with all of you as we take this issue very seriously. Again, as we heard from David, the roadmap for behavioral health care, behavioral health reform that Secretary Sutters over there helped devise and launch when she was secretary, has increased access through the 24/7 behavioral health helpline and statewide network of CBHCs, connecting people with supportive services right in their communities. And with significant support from the legislature through the Behavioral Health Trust Fund, the state has invested hundreds of millions of dollars to programs like MA Repay and others to reduce the financial barriers to workers entering and staying in the behavioral health field, and particularly serving marginalized communities. And while all this work has been transformative, it's clear that we still need to do more. Behavioral health providers have long raised concern about inadequate rates for service, which can contribute to the difficulties they face with hiring and retaining clinicians and ultimately exacerbating access challenges. So the first step is really understanding and addressing so that we can address this issue. And the Behavioral Health Workforce Center's recently released rate study provides us with the data to understand the adequacy of our rate system and the policy recommendations on how to improve it. And this, in turn, we believe will help strengthen the behavioral health workforce in Massachusetts. So I'm very excited to be here with all of you. I'm heartened that this room will be having a hearty discussion about it and really paying attention to an issue that needs the attention. Again, EOHHS is very proud to partner with HPC on this work, and I'm looking forward to the conversation. And now I have the pleasure of introducing Amy Doyle, the director.
Thank you, Undersecretary Secretary Rosenthal and Director Seltz, and thank you everyone here in this room today, everyone who's watching from afar. We really feel and appreciate the support. This is a very exciting day for the Behavioral Health Workforce Center, and I could not be more excited to be here with all of you. So as briefly mentioned, the Behavioral Health Workforce Center at the HPC was launched in September of 2024 in collaboration with EHS to support the state's mission of strengthening the behavioral health workforce and diversifying it by conducting comprehensive research to develop actionable, data-driven policy recommendations. We've also been charged by the legislature with convening key stakeholders from across the public and private sectors to help inform our research and make sure that our policy recommendations are keeping in mind what's happening on the ground in our clinical communities. Our key areas of focus include building equitable education and training pipelines, improving workforce diversity and cultural competency, enhancing professional pathways, and retaining behavioral health providers within communities and settings that help create more equitable access to care for all residents. In addition to working closely with our state agency partners, we convened a Behavioral Health Workforce Center advisory group last year, which is comprised of highly experienced providers, patient representatives, policymakers, advocates, and payers who've generously shared their knowledge and diverse perspectives to help us develop and refine our research and policy recommendations over the past year and a half. This group, most importantly, has helped us bridge the gap between research and practice by keeping us apprised of the successes and emerging challenges within their organizations, and we are so grateful for your time and dedication. Thank you to all of you for the last year and a half of work with us, and especially those of you who are here today. We really appreciate it. Before diving into our team's research, I'd like to take a moment to reflect on the most fundamental reason we're all here today, which is that behavioral health needs are rising here in Massachusetts and across the country. The prevalence of depression among youth and adults rose from 8.2% to over 13% in just a 10-year period, and recent data suggests that rates of developmental disorders such as autism are also continuing to rise. Additionally, between 2020 and 2023, Massachusetts had 8,816 confirmed opioid-related overdose deaths. These alarming increases in diagnosis rates can be partially attributed to several factors, such as pandemic-related stressors, greater public awareness of symptoms and signs of mental health needs, increased screening of children, and decreased stigma around seeking help. And while those last three bullets should be celebrated as forward progress, our fragile care delivery system is struggling to adapt. While the need for behavioral health care continues to rise, recent data indicate it's increasingly difficult to access services and supports, especially for historically underserved communities. In 2023, 23%, or about 1 in 5, commercially insured members use behavioral health services, but 10% of residents who needed care in Massachusetts reported delaying or avoiding that care, in part due to provider shortages across all settings. Both outpatient and inpatient behavioral health programs in Massachusetts reported shortages of eligible applicants, challenges with recruitment and retention of providers, high turnover rates, and unfilled vacancies, which contribute to burnout among the remaining staff in their organizations. Staff who are continuing to commit themselves to working in community behavioral health organizations find themselves taking on additional responsibilities and working longer hours to account for being understaffed and having a higher demand from patients within the communities that they serve. These data demonstrate that strategic spending shifts and increased investments are urgently needed to ensure Massachusetts residents have equitable access to behavioral health care. Due to the critical role that the behavioral health workforce plays in building and maintaining sufficient capacity within our care delivery system, state policy leaders have identified several workforce-focused priorities for which payment reform is a needed strategy. These include increased implementation of behavioral health into primary care, enhancing and diversifying clinical training pipelines, reducing barriers to licensure and career pathways, increasing supports for clinical supervisors, and strengthening workforce capacity and organizational support, especially in lower-cost, community-based settings. Each of these priorities are in alignment with the mission and goals of the Behavioral Health Workforce Center and are top of mind throughout our research process. With that being said, here's 2 of the 3 studies that the legislature has charged the Behavioral Health Workforce Center with completing. These will be the focus of today's discussion, the first of which, as has been mentioned, which was published earlier this week, is a comprehensive analysis of rates paid by public and private payers and the adequacy of said rates to support the provision of equitable, quality behavioral health care in the Commonwealth. And second, to assess licensure and certification processes for behavioral health workforce. And while this licensure study is still ongoing for us, we're very excited to share a few of our preliminary findings and recommendations with you today that we hope can lead to a few small steps in change that will make it easier for our qualified workforce to pursue licensure and move up the career ladder in their roles. The Behavioral Health Workforce Center has been asked to explore some of the most pressing challenges impacting the behavioral health workforce and to identify strategies to move the state forward. And while not a small or simple task, our work is already beginning to demonstrate just how well positioned Massachusetts is to make changes that can bring about meaningful results. The research being presented today is a starting point and should be seen as foundational as our team continues to identify additional questions and topics for exploration, including cost sharing, out-of-network and cash payments for behavioral health services, in addition to analyzing the behavioral health market and service capacity throughout the state. And to make all of this happen, we need your partnership. I encourage all of you to put these findings into action and to continue coming to the table with us to improve the behavioral health care system for our providers and for the individuals and families they serve. And with that, I am very pleased to turn it over to the Behavioral Health Workforce Center's Associate Director, Matt Pecoraro, who will walk us through our research. Thank you.
Thank you very much, Amy, and good morning, everybody. It is truly a pleasure to be here with you all today. I do ask you to forgive my voice. Allergies are getting the best of me, but we will forge ahead, and I have my water. It truly is a joy to get to share with you these findings and select recommendations from these first 18 months of our work. And before doing so, I do want to take a moment to acknowledge that this was very much a team effort. And so my BHWC colleagues, I'd like you to, oh, hello everybody, mostly over there. If you could just raise your hand or stand up as you're able, I'd like to acknowledge Carolina Herrera, Katie Kowalski, Jalen Clark, Nadia Hill, and Tierney Billstrom, all of whom were instrumental to today and all of the work leading up to it. The research is quite clear. For those experiencing behavioral health needs, receiving timely, high-quality behavioral health care is associated with better health outcomes and lower spending in the long run. So as we move through today's conversation, there are a few things we'd ask you to keep in mind. The first being a major finding of our research is that reimbursement rates for the most highly utilized behavioral health service, which is psychotherapy, grew more slowly than inflation. Second, our analysis found that master's level providers delivered most of this care, yet received the lowest reimbursement for their services. You're also going to hear several recommendations to help strengthen the behavioral health workforce. And our aims with these are twofold. First is to address the Commonwealth's workforce capacity challenges by strengthening provider organizations' ability to maintain adequate staffing and continue delivering high-quality services in the most appropriate and lowest cost settings. Second is, as you heard Director Sells refer to, make these reforms by shifting existing healthcare dollars towards behavioral healthcare delivery without increasing overall healthcare spending, raising insurance premiums, or cost sharing. So before diving into the results of our work, let's take a moment to consider who is providing behavioral health care in Massachusetts. We do want to acknowledge that the following slides are not an exhaustive list of provider types. Rather, we're highlighting the provider types who most commonly appeared in the data for the most common behavioral health services. That's licensed behavioral health providers who have an advanced degree. We absolutely expect that future iterations of this work may include other provider types and the peer workforce as well. What you see here is a breakdown of who provided psychotherapy in 2023 as reflected in the commercial claims data. Again, psychotherapy was the most common procedure code billed that year. And as you can see, the vast majority of care was delivered by master's level clinicians, accounting for nearly 3/4 of psychotherapy delivered in Massachusetts. The next largest segment, at 13%, were doctoral level psychologists. Please also note that the workforce reflected here includes providers both with and without prescriptive authority. And while every provider on this slide is trained and capable of delivering psychotherapy and other common behavioral health services, prescribing providers make up a critical yet relatively small portion of the workforce and bring a unique expertise in treating medically complex cases, individuals experiencing comorbid conditions, and those who need support with medication management. Today's conversation is primarily going to revolve around the non-prescribing behavioral health workforce, namely psychologists, counselors, and social workers. So let's unpack this workforce a bit more to get a better sense of who is and who could be providing care in Massachusetts. This slide presents total counts of active licensed behavioral health providers without prescriptive authority. Each requires a master's or doctoral degree, with psychologists requiring a doctoral degree. In 2025, as you can see, social workers represented the largest share of the workforce at almost 60% of licensed non-prescribing behavioral health providers. Social work counts are reflected here in orange bars and include both the independently licensed LICSWs as well as the provisional license of LCSW. It's also important to note that this slide presents active license counts. That doesn't necessarily mean that every provider in each bar is currently delivering care. In fact, we know that at least a portion are likely maintaining licensure without actively practicing. We also know that the workforce isn't static. It changes as people enter and leave positions, the fields, and even the state. The previous slide explored non-prescriber licensure counts in Massachusetts. The BHWC also analyzed BLS employment data, revealing notable and alarming changes, namely a striking decline in social workers employed in the state. You're looking at changes to 3 big bucket behavioral health provider types: psychologists, counselors, which is a fairly wide-reaching bucket and includes folks like LMHCs and LMFTs, and then social workers. And as you can see, Massachusetts has really done a pretty good job growing the number of psychologists and counselors in the field. And yet, despite that notable success, when looking at these 3 non-prescribing license types together, we see an overall decrease driven by a 17% decline in social work, which accounts to about 4,800 providers. This drop in social workers represents a notable loss of very well-trained clinicians. In addition to obtaining an advanced degree, social workers and other master's level providers gain a tremendous amount of supervised experience as they build their clinical skills. By the time these clinicians obtain their independent licensure, they have logged thousands of hours of experience under the supervision of a licensed clinician, with social workers accruing a chart-topping 4,400 hours of supervised experience. The points here are twofold. First, we need to explore strategies to support clinical supervisors and licensed syncing clinicians as they pursue independent licensure and ongoing professional development. And second is we have an outstandingly well-trained workforce, and the rates paid to master's level providers needs to reflect the value brought by their training and their qualifications. And the BHWC thinks that rates play a part in the story. So to illustrate this, we are going to explore several notable findings from the Behavioral Health Workforce Center's report released earlier this week. You've heard mentioned before. And as we begin that conversation, let's take a moment to reflect on why rates are the critical starting point to addressing the state's workforce capacity issue. What exactly is the role? Well, in Massachusetts, as in other states, low payment rates for behavioral health services has been associated with things like clinician burnout, turnover, and difficulty in building service capacity. We've seen this reflected in the literature, and we've seen this reflected in conversations with stakeholders, many of you here in the room today. This is important because payment rates are the primary mechanism by which behavioral health providers and facilities generate the needed revenue to operate and maintain sufficient staffing and program capacity. In order to be sustainable, payment rates must adequately cover the time clinicians spend delivering care, the time spent on necessary and related administrative duties, and then organizational expenses and overhead in general. If payment doesn't cover these rates, costs, behavioral health providers and organizational leaders are faced with a pretty tough choice. Do they continue trying to deliver care with insufficient resources, or do they scale back services and supports, possibly closing down entirely, as we've seen in the state? So we've been talking about the system and how lower rates are associated with provider capacity challenges and contribute to access issues. Providers know all this already, and here's the position they're put in. Lower rates may discourage providers from joining healthcare networks, with Medicaid often being at the greatest disadvantage here. In order to maintain financial sustainability, providers may take only select and often commercial insurance or take only private pay. And in fact, there's reason to believe an appreciable number of providers fall into this bucket, and that may contribute to the disconnect that we see between the number of providers who appear as active, or as available rather, on provider directories, but are not taking new clients, have extremely long wait lists, or don't currently serve any Medicaid patients. So that brings us to how rates are set. For our rate study, we looked at the three major buckets: Medicare, Mass Health, which is the Commonwealth's Medicaid and CHIP program, and commercial insurers. Medicare often serves as the foundation for current behavioral health payment models kind of across the board. A recent study found that a substantive number of provider contracts are modeled off Medicare rules. And historically, Medicare has paid behavioral health providers on a descending scale, dependent on the clinician's level of education and license. You can see the most recent schedule for Medicare on the right side of the slide here. In other words, for a given service, for every dollar paid to a physician, LICSWs and other master's level clinicians see 75 cents for the same service. Mass Health has a public rate setting process in accordance with state regulations, which may include allowing contracted ACOs and MCOs to negotiate rates. Mass Health has historically also used a step-down payment structure like Medicare, but that's recently been changing for some provider organizations delivering care in certain settings, as we'll see in just a moment. And commercial insurers, of course, negotiate rates for behavioral health services with providers, provider groups, or through a behavioral health benefits manager. Again, many commercial payers also use that same step-down model I referenced previously. Okay, now that we have identified the makeup of the workforce and how rates are set, let's explore the rates paid for behavioral health services in 2023. It's important to note that behavioral health services can be provided by an array of trained and licensed professionals. The Commonwealth's high standards mean that providers licensed in the state have completed rigorous graduate education programs, including supervised field experience, as you heard just a moment ago. To illustrate the payment differences in the workforce, we're going to focus on two extremely common behavioral health services: psychiatric evaluations and 60-minute psychotherapy. On the slide here, looking at psychiatric evaluations, Each grouping of bars represents a different provider type. We have physicians on the left, doctoral level psychologists, APRNs, and master's level providers on the right. Within each grouping, the blue bars represent commercial rates, the gold bars in the middle are Medicare fee-for-service for the Boston metro area, and the orange bars on the right are MassHealth. As you can see, the Behavioral Health Workforce Center's analysis found notable rate differences between provider types for the same services, particularly for commercial payers. About 80% of psychiatric evaluations were provided by master's level clinicians, but commercial insurers paid those providers the least, about 70% of the physician price. By comparison, MassHealth paid master's level providers 81% of the physician price, and MassHealth payments were closer across provider types. Now turning our attention to psychotherapy. We see a similar story play out, as shown on this slide. You can see the step-down payment system used by many commercial payers results in master's level providers receiving the lowest reimbursement for psychotherapy by a notable margin. I'll also direct your attention to the difference between commercial and public payers for master's level clinicians, denoted by the blue box. As you can see, commercial payers and MassHealth paid master's level clinicians similar rates for psychotherapy. Just to visually emphasize the difference between physician rates and master's rates for the previous slide, here are those two rates side by side for psychotherapy. Commercial on the left and MassHealth on the right. As you can see, among commercial payers, master's level providers were paid about 66% of the physician rate. By comparison, MassHealth paid master's level providers at 93% of the physician rate. The results of recent rate increases by MassHealth in service to the Commonwealth's Behavioral Health Roadmap, working to decrease rate differences for the same services provided. So far, we've been exploring rates paid for outpatient services, but the BHWC did also explore and identified notable differences in other settings as well. This slide describes commercial rates paid to inpatient behavioral health settings for both adults and children. The majority of this care occurs in non-acute hospitals, about 75% for adults and about 70% for children. As you can see, non-acute hospitals received lower payment rates than general acute care hospitals, about $1,000 a day less. Just like providers, the settings that are delivering the most care are being paid the lowest rates. So as we move toward our recommendations, let's consider how these findings sit in the context of healthcare more broadly. We find that it's not just a question of differing rates within the behavioral health field, but also between behavioral health and other healthcare settings. The Behavioral Health Workforce Center compared the relative commercial prices for behavioral health services to common primary care and specialty services, using claims from physicians in office-based settings to better understand these payment differences. Notably, BHWC found that primary care E&M visits and medical specialty services were reimbursed respectively 2.6 and 6 times the rate of behavioral health physicians by commercial insurers in 2023 for an equivalent amount of time. To illustrate this, for every 1 hour of work by a specialty physician, a behavioral health physician would need to perform 6 hours of psychotherapy to earn an equivalent to commercial payments. For every 1 hour worked by a primary care physician, a behavioral health physician would need to provide approximately 2.5 hours of psychotherapy. And we also know that the issues highlighted today are not isolated to 2023. In fact, over the last 5 years, commercial price growth for psychotherapy has lagged other healthcare growth and inflation. Between 2019 and 2023, the Consumer Price Index grew an average of 3.8%. Primary care E&M grew an average of 4.6%, and psychotherapy grew by just 2.6%. As demand for services continues to rise, Changes in reimbursement are needed to more accurately reflect inflation, provider operational expenses, and the high cost of living in Massachusetts. So what do we do with all this? We are faced with some pretty big challenges, tremendous complexity, and really no simple solution. Moving forward, we need a comprehensive view of economic and service measures to drive payment rate analysis and reform. Some states, including Massachusetts, as well as the federal government, include economic measures like cost of living, wages, and cash pay rates, as well as service measures such as quality and access measures in their Medicaid and Medicare rate setting. Further, the economic realities of living in Massachusetts must also be accounted for. The BHWC found that wages for the behavioral health therapist workforce tended to be lower than wages for other healthcare workforces with similar educational requirements, as you see detailed in this chart. In 2023, the average median hourly earning for a nurse practitioner was just under $67 an hour. For clinical and counseling psychologists, it's just under $48 an hour. And for social workers, it's just under $30 an hour. And for reference, $30 an hour is about $62,000 a year. Said plainly, providers seeking to live and work in Massachusetts need to be able to afford life in Massachusetts. So this brings us to our conclusions and select recommendations. Each one is fully detailed in the report, and I encourage you all to download and read it if you haven't already. And we're really going to touch on these at a higher level here today. And as we move through the recommendations, let's first revisit the major findings that we've covered today. So first is we've established that reimbursement rates for the most highly utilized behavioral health service, psychotherapy, grew more slowly than inflation, and that behavioral health payments lagged other healthcare settings. And second, our analysis found that master's level providers delivered most of this care and yet received the lowest reimbursement for their services, a finding that is mirrored in the inpatient data as well. And as we consider these following recommendations, there are two main objectives that must be accomplished. First is addressing the Commonwealth's workforce capacity challenges by strengthening provider organizations' ability to maintain adequate staffing and continue to deliver high-quality services in the most appropriate, lowest care settings. And second, we need to make these reforms by shifting existing healthcare dollars toward behavioral health without increasing overall healthcare spending, raising insurance premiums, or cost sharing. So our recommendations fall into four categories: provider payments, sustainable payments, mass health payments, and licensure supports. With regard to provider payments, the BHWC recommends reducing payment differentials. The legislature should consider establishing limits on commercial payment differentials, ensuring that master's level providers are paid 90 to 100% of the rate paid to doctoral level providers for the non-medical, office, and telehealth behavioral health services analyzed in our report. Next, commercial payers should consider adjusting per diem payment rates for inpatient psychiatric admissions to close the gap between GAC and non-acute hospitals by increasing rates for non-acute behavioral health hospital admissions. Payment rates for all inpatient psychiatric admissions should also be adjusted for acuity and medical complexity. In support of sustainable payments, we are recommending the state establish minimum payment levels for behavioral health and assess behavioral health price growth. The legislature should consider establishing behavioral health minimum payment levels for commercial payers equivalent to 150% of the Medicare rate for office and telebehavioral health services covered by Medicare, or 150% of the Medicare rate for office and telehealth behavioral services not covered by Medicare. Next, Mass Health should consider increasing per diem rates to behavioral health hospitals and facilities in alignment with reasonable and known cost increases. Finally, CHIA, in partnership with the HPC and DOI, should assess commercial behavioral rate methodologies annually and recommend adjustments as needed to ensure rates are aligned with reasonable and known cost increases. Regarding mass health payments, the legislature should consider targeted financial investments to strengthen and sustain mass health efforts to increase reimbursement for behavioral health providers and ensure the goals of the Roadmap for Behavioral Health Reform are achieved. EUHHS should consider authorizing MassHealth to implement annual behavioral health rate increases in alignment with reasonable and known cost increases, including cost of living and provider wages benchmarked at or above the 75th percentile from the most recent available BLS data. And finally, regarding licensure supports, Massachusetts should consider expanding financial support for graduate level behavioral health clinical field and internship placements to ensure clinical training is compensated at or above the state minimum wage. We also recommend removing the master's level exam requirement for the provisional social work license of LCSW and enabling master's level social workers, LCSWs, pursuing independent licensure to receive cross-discipline supervision for a portion of their required hours by expanding the definition of acceptable clinical supervisors. And finally, we recommend allowing independently licensed social workers to earn continuing education credits for providing clinical supervision to all non-independently licensed behavioral health providers. And with that, I am delighted to turn things back over to my friend and colleague, Amy Doyle, who will bring us into the panel discussion. Thank you all very much.
Thank you. I will introduce our awesome panelists once they get their seats up here. All right. Well, thank you, everyone. I am so excited to be moving into the panel discussion, which I think is what we all need to hear, is what resonates with these folks who are doing the work every day at their organizations and in their communities. And we have such a stellar group with us here today. So please let me introduce. First, we have Leslie Suggs, President and CEO of the Home for Little Wanderers. We have Dr. Jemima St. Louis, Vice President for Workforce Initiatives and Specialty Training at William James College, also a member of our advisory group. And Ken Bates, President and CEO of Open Sky Community Services. Thank you so much for being here. Please, yeah. So I'm going to start with just a general question that I would love for all of you to weigh in on. We just heard a great presentation from Matt with our research findings and recommendations, and I would love to hear from the three of you if anything stood out to you or resonates in particular as you think about your own workforce and your organizations and or the students that you're training. Do you want to start for us, Leslie?
Sure, happy to. First of all, thank you for convening such an important conversation and for all the work that you did and the research that really validates our experience out there in the field. One of the things that at the home, we most of our work is focused on kids and families. We are a large provider in schools, so we have clinicians that are based in public schools. We're in almost 100 schools in Boston, going all the way up the North Shore. And so it's a critical service delivery system for kids who need access to mental health services. And when I heard the data, one of the things that stood out to me is that our rates haven't kept up with inflation, which certainly is our experience. All the other data points we know. ABH has been following that for some time. I also am the chair of ABH over the past 2 years and have been very active as they have worked to highlight this the rate structure as it supports mental health clinics and behavioral health work. But I think that note in particular, it's really staggering that we're asked to continue to provide, lean in, respond to an unprecedented mental health crisis, yet our rates don't keep up with the cost to deliver that service.
Good morning. Thank you certainly for this wonderful opportunity, and thank you to everyone who contributed to this wonderful report. Clearly, at William James College, because we are a school of psychology where we train mental health counselors, psychologists, school psychologists, etc., this is an important report for us, specifically from the standpoint of recruitment and retention in the field. So one of the findings that certainly stood out for me pertained to the fact that the workforce is primarily supported by master's level clinicians. And yet to look at the figure that for every dollar paid to their counterparts, they're earning 66 cents, that's heartbreaking. And certainly we understand that that is one of the key factors that contributes to significant rates of burnout in the field. And also looking at the data that demonstrated that we have lost about 5,000 social workers. Again, thinking about these are the individuals who are the backbone of the workforce, and to see that decline certainly speaks volume. And we have to wonder about what is our commitment as a school when we are training, when we are recruiting individuals to come to the field, knowing that after years of training, years of field education experience, they finally cross that finishing line into being licensed providers, there is still no guarantee that they will continue to earn a significant amount of money to remain in the field. And that is, from our perspective, a critical workforce crisis that the Commonwealth really needs to address.
Good morning. Matt, you had me at 75% BLS. I have to say, we got at least one here. I want to thank the Health Policy Commission and Amy and the team, Matt and everyone else who put so much time into this. I think when Amy started, she immediately began to call community providers and connect and really understand what's happening in the community. And what stood out to me, Matt and Amy, when you talked about really needing to make a shift. We have tremendous needs in our community, serving people with very, very complex challenges. We are the behavioral health, we are the safety net in our communities. And I believe wholeheartedly we need an incredible shift away from health systems into community. So I look forward, David, to you and your team and the legislature and everyone continuing to push to move dollars into community-based systems. I've had a few conversations with some health system CEOs recently and over the years. And when I say that we have an army of community providers, an army of staff, outreach staff who are on the streets, in the communities, in people's homes, how do we align our system? How do we align our system to pay those, to pay reasonable, adequate rates for those staff in our communities, in our health centers? We know the result. We know the result that people are going to be healthier, happier, living at home, in their homes. The responses generally are, I can't afford it. I don't know how to make this work financially, which quite honestly blows my mind. We have billion-dollar health systems out there. We've got to shift those dollars into community-based settings in order to keep people at home. I'll stop for now.
Thank you. And Ken, I'll follow up with you next. What do you as an employer need from the state to build up your supports and to be able to maintain sufficient workforce capacity? And where have you've had some very innovative internal workforce initiatives the last several years. Where have you found success?
I think we need predictable and sustainable rates. Thank you very much. If we say that once, we'll say it 100 times. We also need our state and we need our Mass Health partner to hold our health plans accountable, our Mass Health plans accountable. We know, some of us know, we chase dollars all day long. We spend inordinate amount of time, inordinate amount of money and staff time chasing claims. Our ACO, our ICO partners really need to get a lot better at paying claims. And here we are in the community chasing them every single day. However, we'll move to the positive, because I think what we've got to do is continue the investments that we've made in the state. Secretary Sutters, I know, many years ago started to move the system toward community-based recovery coaches, family partners, peoples in our community who really make a difference and who can really impact families. We've got to continue to move in that direction. Recruiting is one thing, retaining is another. We've got to bring people in, we have to grow. And the investments we've talked about today around supervision, paid internships, making it easier to become licensed. Those are the things that help keep people in our clinics, in our community-based settings. Those are the people that keep people here growing while they're with us, and then having them, of course, stay with us to continue to impact. So, thank you.
Thank you. Leslie, I want to ask, I know a lot of these topics and discussions really are broad and can be general and true across the entire care continuum and the entire system, but I would love to hear your perspective on what does the workforce specifically serving children and families need, and what can the system do to better support those needs?
You know, when we met before, I shared with you, often the conversations start with, well, how do we make the experience of providing care in mental health clinics more pleasurable for clinicians? How do we think, let's decrease documentation. Let's think about training and professional development and culture, and all those things are incredibly important. They're good questions and things to think about. But in truth, it comes down to what we're able to pay clinicians to do this work. It just does. Clinicians come in with a lot of heart and passion. Many of you, how many of you are actually providers out there, right? You got into this work because you care, but you also have skills and expertise and training, and that means something. You've spent a lot of time on your education, and you should be compensated at the level that you've invested. Every kid and family that we serve deserves to have high-quality interventions, folks that understand how to treat depression, how to treat anxiety, how to do good family work, and to be able to invest in their own training and professional development. So what it really boils down to, when I think about just in our clinic alone, we have on average 300 to 350 kids waiting for therapy on our wait list. Aisha, did I get that right? Yeah, that's about it. And I get asked, how do you solve that? Well, if I could simply hire clinicians and keep clinicians who are attracted to private practice, you get your LICSW, why wouldn't you go and set up a private practice, at least half-time, part-time, because of what you can charge, and the need is out there. So it does boil down to rates. Organizations can be more efficient. Some of the things that Ken talked about in terms of chasing reimbursements, we can fix that. We need to pay attention to that. But at the end of the day, it comes down to the reimbursement rates that we get and what we're able to pay clinicians coming out of school and when they get that advanced licensure, and keeping them in the field. I'll add one more thing, since I have the mic and I'm a bit on my soapbox here. The kids certainly that we serve at the home have a great deal of complexity. And it truly breaks my heart to think that there are kids waiting for a clinician. That is a kiddo that somebody is worried about. A teacher is worried about that kid, the school nurse, a parent. This is a kiddo that is not functioning at the level that folks feel like, that they're hurting in some way. That means they're not accessing academic material. They're maybe not engaged and have good friendships out there. Somebody's worried about that kid, and they're waiting for services. To be able to meet that need, if we could simply attract more folks to the field, we could meet that need. I'll just pause there.
Thank you. Switching gears a little bit to the pipeline, Jemima, I would love to ask you, what is the role of graduate training programs in addressing these problems, and what can Massachusetts do to support clinical students, trainees, and supervisors and faculty?
How much time do we have? No, that's a wonderful question, and I think it certainly delves very nicely with what you just mentioned, Leslie, in terms of bringing more talents into the field. So as a graduate training program, we view this workforce challenge from the perspective of both recruitment and retention. We understand how critical it is for us at the recruitment stage, because we basically serve in an entry-level capacity for the workforce. It is important for us to be intentional about who we recruit, how we train, and how we support students during their training while they are in graduate program. Because the individuals who come into graduate school today are going to be the ones who are in the workforce 5 to 10 years from now. So it's important for us as an institution of higher learning to also be intentional about ensuring there is diversity reflected in the workforce, diversity in language, diversity in terms of culture, because we know what the data certainly shows in terms of identity match mentorship for students who are in graduate school, as well as identity match clinicians for the workforce that is certainly in critical need. From a retention standpoint, I think certainly graduate schools play a critical role in ensuring that we are equipping our graduate students with the skill sets, the knowledge, the expertise, not only to deliver linguistically and culturally appropriate services, but also to be prepared for the next step in terms of licensure. Because we know if students graduate and they are unable to secure licensure, that's going to create even more challenges in terms of their ability to function independently as practitioners and their ability to certainly provide clinical services. So we see our roles, in essence, as being able to be actively engaged both at the recruitment and the retention end. But also, we know graduate school is expensive. Part of what we don't talk about often is the significant cost that is associated with pursuing your master's or doctoral degrees. It is very expensive, and it can be a significant barrier, specifically for individuals who are from economically disadvantaged backgrounds, first-generation students. So Massachusetts, I know, has done a pretty good job so far in figuring out how best to provide scholarship support. We have loan repayment programs, but clearly more is needed because based on what we are seeing from the data, that we are losing clinicians. So how do we continue to ensure that we are putting those services, those resources in place to continue to grow the pipeline? I could go on, but I'll stop right there.
No, please. I have a related follow-up question since you brought up the cost of education. Zooming out, this is not a specific problem for Massachusetts, but the country is now grappling with restrictions on student loans and maybe some additional barriers and policies that have been newly implemented or are forthcoming. What do you anticipate the impact may be to current students or prospective students, and how is William James thinking about this?
Yes. So what William James College has certainly done intentionally in light of changing policies at the federal level is that we have remained mission focused. We know data do not lie. The statistics certainly are pretty compelling in viewing, based on some of the findings from the Workforce Center's research studies. I think we are seeing certainly that this is not the moment to turn away from our practices. This is basically the time for us to really be much more intentional about where do our priorities lie. If we are going to address the behavioral health workforce crisis that is facing our state, this is not the time for us to pull resources away from providing scholarships to students. This is not the time for us to reduce our resources in support to provide stipend for students who are working hours in the field and not being paid. And we know how burdensome that can be in the long haul for our students. So one of the strategies that we have certainly utilized at William James College is that our board voted to allow more scholarships to be put in the pool so that money doesn't become the barrier that attracts students to the field. And this is why I'm really proud that we are here in Massachusetts, and there's a lot of intentionality, certainly at the legislative level, to invest in behavioral health workforce development, but certainly what we are seeing, the pattern certainly that's being exhibited at the federal level is not really encouraging. And I think this is my personal opinion, not that of William James College. It's really short-sighted because the crisis is not going to be resolved by removing resources. We need to continue to move forward with the legislative agenda that we have here in Massachusetts.
Thank you.
Amy, if I could just build on
Please.
what Dr. St. Louis just said, I think that the philanthropy in our community also has played a significant role. Marty, he doesn't hide anymore when we bring up the wonderful foundations that have provided support to us. At Open Sky, we have over the last few years used a lot of the investments that have come through the Workforce Competitive Trust Fund. A lot of resources have come to build a cohort program and a pipeline program, getting immigrants and new folks to the field, into our field, with support from Accelerate the Future and other foundations, and also, in our instance, Framingham State University. We've been able to offer free tuition and LMHC programs to 20 students, 20 folks who were not licensed, who I think this August will become licensed. So I think it's really aligning the state with community partners and others to help address some of those barriers. But there are dark clouds ahead, right? I mean, the Workforce Competitive Trust Fund, I mean, how much more is there? How do we embed those funds into the rates, right? So that it's not a sort of, okay, this will last a couple of years and then you've got to figure out how to make it work. And that's where a lot of my colleague is ready to go. That's where a lot of us are. We're getting ready for what's about to happen and how do we sustain.
I don't dare talk over you, Ken.
Go for it.
I never talk over you. I just wanted to share that yesterday, the Home Florida Wanderers had their first cohort from Accelerate the Future, who's graduating this year from Framingham State. And we had our celebration at our mental health clinic yesterday, 20 individuals who are graduating with their master's in counseling. And it was just such a fantastic, special day. Folks that would never have ever been able to go back and go get their degree. I often say, loan forgiveness is wonderful. The significant investments there have been life-changing for so many people, but you have to get the loan in the first place to be forgiven. So if you can access education without having to do that, what an incredible gift. And I wanted to make the point earlier too, and I thought I had this thought yesterday as I'm hearing the testimony from the folks that worked so hard over the last 3 years to get that degree. We need them to stay in the field. And I said to them, we need you to stay. You need folks with, again, that continued skills and expertise. When you get that advanced licensure, I need people to stay. The kids that we serve have complexity. We need folks that have had that are seasoned, who've had that training to mentor and supervise others and provide that expertise. And so, again, agree with my colleagues here, a lot more investment is needed so that that we learn from those experiences of a model like Accelerate the Future, and that we can expand and make those investments because we know it works. And I particularly like the partnership with Brandeis that Accelerate the Future has to really look at, okay, did this work? Did people stay? Are they still providing community-based mental health work? We'll know the answers to those questions in the next few years. But what a privilege to be able to have had that cohort participate.
Mm-hmm.
Thank you. Yeah, this is a perfect segue. Actually, I would love to hear from both Leslie, you and Ken, a little bit more about the details, the core components. What makes these programs work? I heard you say that these are individuals who likely never would have gone back to school to pursue an advanced degree. What is it about these programs that enable them to do that? What are the key supports and components that folks need to be able to pursue higher education and these clinical career pathways?
What I heard directly yesterday from our workforce who participated in the program, it was, first of all, their supervisor believed in them and encouraged them to apply and said, hey, you've got experience, you have expertise, go back and do this. So somebody coaching them. It was the flexibility from us as an employer to say, yes, go, take that time, do the hours. Folks met on site at one of our programs. They had online learning, but they also met once a month in person. And it was the flexibility around their internship. About 70% did their internship at the home, and about 30% did an internship outside of our organization, because we wanted them to complete this. I would about 80% of that cohort of 20 are staying at the home, and about 20% have found jobs elsewhere. And I think that's a win, because it's about bringing people into our sector, not necessarily staying at the home. But it was really that collaboration and the mentoring and the understanding of what it takes that allowed them to get to the finish line of that 3-year process.
Yeah, I would just add and echo that really the financial investment on behalf of the home, right, and Open Sky and other organizations who have the ability to do this. There are a lot of community providers that don't have the ability to invest in something like this. And we can only do that when our bottom lines allow us to do that. And so back to Matt, you're going to get us the 75th percentile. I know you will. But I think getting back to reimbursement, it does come down to that, and a willingness to use those dollars.
That's right. None of us could operate mental health clinics if we didn't operate all other kinds of lines of businesses. We just would never have the cash flow, the operating capital to run those clinics, because they lose money. Good year, you break even. So all this, these innovative professional development programs, think of the creativity, the lost productivity because folks are participating, that would not be possible, in my opinion, without embedded in an organization that can tolerate the ebbs and flows and has a diversification of revenue stream.
Yeah, for years at Open Sky, we very intentionally didn't grow our outpatient services. There was such a demand, but we couldn't financially. We couldn't go down that path, because it's a running joke, not so much a joke among our colleagues, is how much are you losing this year in your outpatient clinic? We have a psychiatrist who wants $340 an hour. So if you pull those slides back up, you can do the math very quickly. You can see that it doesn't work. And if you take the reimbursement for a master's level person, and just, if they're going to have a life, they're going to do about 25 units a week, maybe 42, 44. If you work for the Health Policy Commission, you're probably doing 48 weeks a year. Just kidding. But you add that up, it's about $110,000 a year in revenue. And the cost to chase the $110,000 and the overhead that goes along with that. And we're paying our folks, $80,000 now, which is good, $85,000. The margins, we've got to pay our social workers almost $90,000 a year. You can't make money in that business model. And that's, with what's ahead, again, I fear with what's ahead, the tough times ahead are going to force some clinics and providers to decrease access to much needed services. And back to the safety net, ERs, inpatient, and other places are going to get a little more crowded.
Yeah. So we talked a little bit about getting folks back into higher education and pursuing their degrees, getting that experience they need. And then there's licensure, which we know from a recently published report from the team at William James and the Blue Cross Blue Shield Foundation that there are some barriers that a lot of folks who are going through the time and investment and the financial burden of pursuing these degrees and getting this years of experience are still then not achieving licensure. And Jamima, I wonder if you could speak a little bit to what some of those barriers are and what we can do to address that.
Sure. So we conducted a study about a year ago in partnership with the Blue Cross Blue Shield of Massachusetts Foundation. And the report was issued in 2025, September 2025, and is available on their website. And what we did was to ask the question as to what were the critical barriers to securing licensure here in Massachusetts, and focus specifically on clinicians as well as graduate students who were finishing up their year of training, and those who identify as BIPOC, clinicians who identify as members of the LGBTQIA community, and those for whom English is a second language, because we know from the data communities that are from underserved backgrounds tend to face the greatest barriers when it comes to pursuing licensure. And some of the findings were pretty striking, one of which certainly has national implications. We found that for social workers and mental health counselors, again, remember, they make up the vast majority of the behavioral health workforce. Only 43% of social workers and mental health counselors will ever achieve licensure. 43%. We are, in essence, losing more than half of the workforce. And these are, again, individuals who comprise the vast majority of our behavioral health workforce. And why? We found out that certainly financial costs are a significant barrier because it's not sufficient for you to just get your graduate degree, right? You have to pay for the licensure exam, and each time you fail, you have to pay again and again, the study prep, the supervision that's required. What we really observe is the fact that licensure is an important component on that journey toward achieving independence as a practitioner. But licensure, in essence, is basically serving as a gatekeeper for who gets filtered in and who gets filtered out. And here in Massachusetts, you can't practice independently without having a license. You can't supervise unlicensed individuals, which basically creates this significant bottleneck in the state, in the workforce for us. And when we look across the nation, what we found is that there's a lot of states, including our neighboring state of Rhode Island, that did away with the licensing exam for social workers. I see 2 thumbs up going on in the back. And within the course of a year, they saw a 160% increase in rates of licensed social workers. Connecticut, Nebraska, and other states have similar policies in place. Now, I want to be very clear that I'm not anti-licensure, because I do understand we need to be sure that individuals who are caring for some of the most vulnerable members of our community, that they do have the adequate training, the adequate experience and expertise, et cetera. But as the data again showed, it is not due to a lack of clinical training, because social workers, for example, are at the top. By the time that they're done with their graduate studies, more than 4,000 hours of supervised training. So what purpose then does the licensure serve? Does it really show that it is an issue of competency, or is it really being utilized simply as a way to keep people out of the workforce? So again, the study is available on Blue Cross Blue Shield's website, and I would certainly encourage you to read the findings.
Thank you. Is there anything, Ken or Leslie, hearing that and the barriers to licensure and thinking about who you're trying to recruit and retain in your organizations? Is there anything you'd like to respond to?
Our staff work really hard, and they work a lot of hours. And to your point, they're working 50, 60, 70 hours a week to make ends meet. And how do you ensure that you get those 4,000 hours? How can you do 20 hours unpaid on top of that, or somehow weave that in? It's incredibly stressful, and I would assume that's why a lot of people can't make it and drop out of that licensure process. They remain in the helping field, which we're incredibly thankful for, but often again the reimbursements decrease when that happens.
I think licensure is very complicated, and I think it is important that that people demonstrate those skills and expertise. I think there's something that comes with you've trained, you have an education, and there's a proclamation that yes, I am a skilled, qualified provider that has the knowledge and the expertise to provide treatment. So I think that's really important, and I think it's that we don't want to back away from that. I do think helping and supporting and those programs that can help people get through the licensure process, including that exam, is important, and we need to make investments there. And then I think the juice has to be worth the squeeze. You get that licensure, what's the salary that comes with it? What's how is that work honored out there in the provider community and mental health clinics when you go out to do that work? There has to be motivation to do that. So I think we need to consider those two things as well.
Yeah,
Go ahead. Absolutely agree. And looking really at the constant devaluation of behavioral health across the board. And we see the same devaluation before licensure and after licensure. What's the rationale for not paying students for working 20, 24 hours a week? Right? We are basically sending a message that we do not value the contributions that they bring to our organizations. And the inequities that exist in the pay rates. What's the justification for paying a social worker 60 cents to $1 for a psychologist? What is the message, again, are we sending as a field? So the devaluation happens throughout the course of the workforce. So we should not be surprised that people burn out, that they leave, and they do not want to remain in the field.
yeah, thank you. And Jamima, I heard you mention from your report, I appreciated the focus on underserved communities. You mentioned it's the rates of passing the licensure exam and achieving licensure for BIPOC and LGBTQIA. What are some things that the state could do, or what are some things that William James is doing to help address some of those disparities that we're seeing?
So at William James College, part of what we do is, as I mentioned a few minutes ago, it's not just the recruitment of the students, but the retention efforts. So putting in mentorship and supervision early in the process for students, because one of the findings indicated that students often do not pursue licensure because they can't find identity match supervisors. So ensuring that we connect them at that level and provide them with the support, the resources that they need to cross that finish line. In terms of more broader state level advocacy in legislature related efforts, I think right now is prime time, because there are a number of legislative agendas that are currently under consideration. We need to support the Social Worker Compact. If you are not familiar with that, I see lots of heads nodding. We need to support the Mental Health Counselor Compact as well, the Psych Pact that is currently under consideration. It requires a coordinated effort and investment on the part of organizations, of individual clinicians, of graduate programs to really push our legislative members to understand that this investment is not just an investment that's going to support individual clinicians, but it is an investment that's going to support the communities that make up the Commonwealth. So Super PAC, please call your representatives and ensure that they are supporting these legislative mandates.
Thank you. Leslie, I want to switch gears a little bit. We've been talking a lot about rates and compensation and pay, of course. And recently I heard you bring up a few other challenges of what maybe contributed to burnout and some retention challenges related to the administrative burden and some of the other maybe unnecessary barriers that contribute to long hours and challenging work-life balance for your staff. Could you speak a little bit more to some of those challenges and what we should be thinking about to address them?
Yeah, I think what comes to mind is not a surprise to folks. It's constantly having to legitimize or defend a treatment plan. It's the authorizations. It's the meeting medical necessity. It's the incredible assessments and cans and all of those things that we ask clinicians to do. That in addition to the work that we're doing, our workforce is under a microscope in terms of the care that they're providing. And so thinking about those things, that's, again, another reason why I think private practice is attractive, that you don't have those burdens go away. I think also just the sheer volume that we ask people to get to in terms of productivity is really challenging to be able to hit those numbers. So people don't have this time and space necessarily to just simply be in the work. I think about our clinicians that are in schools, embedded in schools, they consider themselves partners with principals and teachers, and having that time to really be able to just sit and talk about a kiddo in a way that contributes to the work. I think those are all challenging experiences. But I'm hopeful about the things that are ways in which we can create efficiency and that are exciting. We've been talking a lot about in our organization about leveraging AI, for example. Telehealth has been a fantastic platform. Who knew that we could, our engagement with families has tripled because we're able to have a call with a parent. We're able to do a family session, work through a crisis on telehealth platforms. So there's a lot of really cool and innovative things. I'm stunned that there's VC money coming into behavioral health. So somebody thinks you can make money at it, right? So let's think about how we leverage those kinds of efficiencies. And then I'll go back to rates, because to be able to think about that kind of innovation, you have to be in an organization that's got the working capital to be able to put dollars and resources aside to think about those investments, partners with others, bring that kind of expertise into your organization, into your business model, so that you can leverage it to see what's possible. But I think it's also an exciting time to think about those things and how we make that easier, just from a documentation standpoint, to how we actually provide better and higher quality care that's accessible to folks out there by leveraging the innovation that's going out there in our communities.
Yeah, thank you. Anything to add, Ken?
I thought I was a glass half full person, but you beat me there. I think some of the similar themes we heard earlier about the tension, David mentioned the tension that exists in our system. We, as employers, we have 1,300 employees. You probably have the same amount of, we've got a lot of employees. We've got a lot of folks out on Paid Family Medical Leave Act, and that incredibly impacts our ability to deliver good care. Our health insurance costs increase incredibly every year, putting additional strain on our ability to deliver good care. So I think there's some real tension infrastructure that we appreciate the Health Policy Commission's attention to moving forward. We know what works. We've seen it. We've talked about it. We all know it. We all know what works. It really, what I'm excited about, Leslie, is the opportunity that we have ahead of us. And this push with Health Policy Commission leading the way with the government to really align and put our money where our mouths are, put our money in the community to help people stay at home, healthy, happy, very, very complex issues and challenges ahead of us. So I am excited and look forward to continuing to help push.
Great, thank you. And as we're pushing for these reforms, while we're still grappling with some of these challenges, you have been, as you have been for many years now, is there any advice or lessons learned that you could give to other organizations in similar situations, sort of as they're looking at operating their business and trying to retain their staff, and staff asking for raises or asking for more time off? What's some advice or some things that have worked for you, or maybe not worked for you, that you
I
would
follow
share?
Leslie. She says, "Call Accelerate the Future." We call Accelerate the Future. In all honesty, it really is about collaboration and partnership and sharing best practices. And we come through ABH and we come together in our trade associations to work together to address the challenges that we have ahead of us. So I think for our colleagues, for all of us, we have to continue to work together to share best practices and to collaborate on the ground. In Central Mass, we work very, very closely with Seven Hills and Spectrum Health Systems and other. We know what works. We have great relationships, and we bring our expertise together to make a difference. So I think partnership and collaboration is real, and stealing great ideas.
Do you have anything to add, or sounds like Ken took everything from you, as he's learned from you? So would you like to add?
I do think it's important that our workforce hears every day that they're our most important resource, and that what they do matters, that they are changing lives every day. Because you can lose that a little bit. Like, what, am I having the impact I thought I would? It's important that we validate each other, that we call that out, that we honor the work and the expertise out there. And I think that goes a long way in building culture and helping people stay in it. People stay in organizations because they are connected and appreciate their supervisors and the people around them. They spend most of their time with those individuals. So those things matter a whole lot. And it also matters when they hear leadership say, there was a time when it wasn't okay to talk about compensation, that somehow to do this work I'm a social worker, by the way. I don't even think I said that, social worker. Thank you. I got my master's degree so long ago, there actually was not a state school that offered a social work degree. So I went to Simmons, and a significant amount of money later, I got a $2,000 increase to my salary after my master's degree, by the way. But that the work that we do, that they do matters. I was going to say, there was a time when it wasn't okay to talk about social compensation, that somehow by doing this work that you had signed a vow of poverty, that this was all about passion and heart. And I think it's important that folks hear me say, that's just not acceptable. We are going to talk about compensation. We're going to I should be able to recruit talent just like Mass General Brigham, recruits a top cardiologist to come and work in and we need to say that. It's okay to say that. And that advocacy followed by some actionable, intentional action means something. So I think, that part's important too.
Yeah. No, I appreciate that very much. And Jemima, I would love to give you a chance, both as a clinical psychologist and as someone who is every day talking with students and thinking about this as folks are considering where to go with their careers and what to do with these degrees. How are you having these conversations with your students?
It's interesting because we are in the middle of recruitment for next year, and every year we see a significant increase in the number of students who want to come into this field. So there is the desire, there's the passion, and we see certainly an eagerness, specifically from individuals with lived experience, to come into the field to make a significant impact. And I think our responsibility as an academic institution is to ensure that that passion not only continues to exist, but that we nurture it in a way that students continue to feel supported, continue to feel valued, and continue to feel that they're making a significant impact in this field. And this is why it is so important for us as academic institutions that we actively engage with our lawmakers to ensure that the practices, the policies that are being implemented at the state level do benefit our students so we don't lose them in the long haul.
Yeah, thank you. And sorry, I'm going to keep picking on you, Jemima, because the topic of supervision and field placements, which are often unpaid clinical placements, how do you navigate this as you're helping students find their field placements and thinking about our I would say right now, maybe a not so coordinated network of supervision and field placement opportunities out there? How do you navigate this as the school and in conversations with your students?
I think it's a multi-pronged approach, and I would echo what Ken said earlier. It's about collaboration. You cannot do workforce development without relying on partners, and certainly our community-based agencies, both Open Sky and the Home, serve as field placement sites for our students. And I think it's also about advocating at the organizational level, given certainly the financial constraints that both colleagues have expressed, and advocating for some investment in support of our students, because we know certainly when students feel valued, not just in words, but in action, there is a greater level of interest, certainly in remaining in the field. So we do the advocacy at the organizational level to see in what capacity are you able, even if it's minimum wage, to pay students for their field education experience. We also work in collaboration with foundations, with state and federal agencies. We are constantly writing grants to bring field education placement stipends for our students, again, to help alleviate that financial burden early in the process. So it is a collaborative partnership. It certainly involves a lot of advocacy and boots on the ground, and for us to find out where can we raise money so that by the time our students leave our institution, they are not burdened by the financial cost of pursuing a graduate degree.
Please.
Something came to mind, and I use it as a kind of a talking point and also as a model. Folks remember, after the pandemic, we had sort of the Great Resignation, and it was the first time that I saw the business community step up in a meaningful way to address access to childcare, because all of a sudden there wasn't a workforce back in the office, and folks were really challenged. And I think it speaks to, and so the Business Roundtable stepped up. There was a lot of conversation right here in Boston about how we make access to daycare more affordable. They needed workforce. They needed women to come back into the workforce. It was a big effort, and that piece of legislation passed after that effort. It speaks to the private-public partnership and the power of that to solve a problem. And we have a behavioral health workforce crisis. We did before the pandemic, and by golly, after the pandemic, here we are. And not a whole lot has changed. Significant investments. We're lucky to be in Massachusetts. I grew up in Texas. I mean, we are lucky to be here. We've got a robust system, certainly on the kid behavioral health side, but we've got to be able to staff it. It means nothing if you don't have a workforce. So that model gives me hope when folks start realizing, no matter the demographic, I've got a kiddo that is struggling. I have a kid that's anxious. I have a kid that's having a hard time in school. We saw that after the pandemic. When that impact is felt across our communities, think about what we can accomplish and the challenges we can solve around workforce when we have that kind of partnership. So just echoing that the collaboration and partnerships that need to continue to happen out there.
And if I may add, you ask about supervision too, and I think that's another component of the workforce that we don't usually talk about. So part of what we have done at William James College is when we are pursuing graduate training grants, we build in some funds to to compensate supervisors for their time. Above and beyond what they are earning at the organizations, we build in an honorarium because we oftentimes rely heavily on supervisors, but don't take the time to actually acknowledge the significant contributions that licensed supervisors make in training our students and ensuring that they have the clinical skills to do the work that we do. So I think any approach that's going to be sustainable from a workforce development standpoint also needs to acknowledge the significant contributions that supervisors make in the field and to be compensated for those efforts.
Thank you. Do you want to add anything before
Did you
do
just get the claw? Was that?
We're going to move into
that
our
all right?
last question, but I could see you leaning, so I
ju-
wanted to give you a chance to
Yeah,
respond.
no, I echo, again, my colleagues here, and what I would add, too, is the value-based results here in terms of saving costs and shifting dollars to the community to save more. So every person that doesn't show up in the emergency room, every person that doesn't go back to jail, every person whose family's able to stay together, there are significant costs to be saved and reinvested back into families and communities. So it's always a focus on cost.
And this is, I saved the toughest question for last, but of all the things we've talked about, I would love to hear from each of you if there's just one thing you would like to leave this room with, the policymakers, the legislators, something you wish they knew that we haven't addressed today or something that has been raised today. What's the most immediate and pressing next step? What should the state do to start taking action today?
I just want to say we've talked. We all know what needs to happen,
We do. It's simple.
and to hear David and others in the room, Undersecretary, talk about working together. It starts at the top too. Our governor needs to continue to invest in mental health and community-based services. We need to continue to fight for rates at the 53rd. We hope to get to 75. We're trying to hold on to 53%, right? So we've got to get our legislators, our governor, everyone to continue this focus on community health, community behavioral health services for the good of the Commonwealth, really, for the good of the Commonwealth. And if we're to shift the equation, if we're truly to shift to become a more equitable, a more safe, happier community, if you will, we've got to invest in community services. We know what we have to do. We just have to do it.
That's exactly what I would say. I mean, that we know exactly what we need to do. Everything you said, Ken, around prevention, keeping families together. If you think about the cost of providing a behavioral health session to a kiddo and some family intervention to a family versus the cost of a child coming into care because a family is so stressed they can't do a good job of parenting, all of that is so true. And so shifting those costs, making those investments, simply having behavioral health rates that are part of the Chapter 257 process, where we get regular rate reviews every year that keep up with inflation so that you can plan and develop and innovate and all those things, that would be a game changer. I mean, that if we made those kinds of investments, we know what we need to do.
I couldn't agree more. And I think certainly the findings from today's research indicate certainly better rates is going to be part of what's going to sustain the behavioral health workforce. And I appreciate the fact that the report, the findings are very clear, they're very concrete, and very much aligned with what's happening at the State House. Additionally, from our perspective as an academic institution, it's important to recognize that reimbursement rates and licensure are two sides of the same policy lever. And you cannot address one without focusing on the other. And it is critical as we are thinking about strategies to not only recruit and retain and sustain the workforce, that we look into exam reforms similar to what other states have done and have successfully done to increase the number of licensed providers in the field.
Thank you. With that, thank you all so much for your time today, for being here today, for your reflections. You are welcome to step down, and
Thank you, Amy.
thank you so much. While our panelists are taking their seats, I will move us into the final section of our event today. And our first speaker to give some closing remarks, I am so excited to introduce Representative Mindy Domb, Chair of the Joint Committee on Mental Health, Substance Use, and Recovery. Chair Domb brings to the State House decades of experience as a community organizer, public health educator, nonprofit executive, advocate, and policy expert. She has developed innovative services through partnerships, community education, community coalitions in Western Massachusetts and across the state. Under her leadership, Chair Domb has advanced critical legislation to expand Massachusetts residents' access to behavioral health care and address challenges facing the behavioral health workforce. We're grateful to have Chair Domb join us here today as we discuss some of the greatest challenges facing the Commonwealth's behavioral health system. And please join me in welcoming Chair Mindy Domb. Thank you.
Good morning, everybody. I'm Mindy Domb. I have the honor and privilege of representing the 3rd Hampshire District in the Massachusetts House of Representatives, which includes the town of Amherst and half of the town of Granby. I don't know if anybody knows Granby, but it's right over the notch. And I also, as you know, have the privilege of being assigned to be the chair of the House chair for the Joint Committee on Mental Health, Substance Use, and Recovery. And I share that position with my Senate counterpart, Senator John Vilas, who also happens to be from Western Massachusetts. It's just a coincidence. Usually that doesn't happen. I also want to say that I want to recognize and thank the Executive Office of Health and Human Services, Undersecretary for Health, Amy Rosenthal, for everything that you do and for being here. I also want to thank the Commission's Executive Director, David Seltz, and also the Commission's Behavioral Health Workforce Center Director, Amy Doyle. All of you, much gratitude and appreciation, taking so much time out of your day to sort of think through and explore these tough issues around the behavioral health workforce, and I'm really grateful to be part of it. Just listening to the small piece that I got to be able to hear in the last panel, I think our committee's researcher, Gwen Bankman, who's been here all morning, is coming up with quite a to-do list for the committee, which is a good thing. It means that there's not only issues for us to think about, but there's ways for us to think about partnering together. So I'm really excited about that. Before I get into my written remarks, I just want to say I came here this morning from an event that's being held on the Common with the Ducklings for the Children's Mental Health Campaign. I have to admit, it's my first invitation to ever do something with the Ducklings. I wasn't going to say no. And they were dressing them up in green ribbons for Children's Mental Health Awareness Month and Week, and then coming here to talk about the workforce. There's a thread in my day that I don't usually get to see, which connects the families that are in need and who are advocating for services and the people who want to make sure that there's someone on the other end so they can get those services. So just as I thank the families for the care that they're giving their family member and their children, thank you so much for what you're trying to do to make sure that there is care on the other side of that need. They also speak about stigma and how that affects their ability to not only get support from their community and their family members, but sometimes even the first provider that they may disclose a problem to, and how that awareness also helps to break that stigma. And my prior work with HIV and AIDS has made me very acutely aware and knowledgeable about the role that stigma can play in public health and in harm. And I just want to say that you being here today is also another way that we break that stigma, and you sharing whatever you learned today with someone in your life who may or may not even be in the field, but who you want to sort of communicate the importance of this to, helps to build that awareness. And trust me, that's what's going to help move the legislature. So I really want to thank the Health Policy Commission's Workforce Center, and today's panelists for their commitment to investigating and brainstorming policy solutions to strengthen the behavioral health workforce in the Commonwealth. Building a skilled and engaged workforce, and we've heard this morning, is essential to ensuring access to treatment and care. We can't talk about access without talking about workforce. Without the providers, our efforts are futile. And allow me to qualify that statement by saying without the human providers. I'm not talking about AI here, I'm talking about people. As many of you know, in 2021, the legislature took swift action to pass legislation to address COVID-19 needs and leverage over $2.5 billion in federal ARPA money, which were made available for states to respond to the global public health crisis. Here in Massachusetts, many of you were involved in this effort. We overwhelmingly directed these dollars to healthcare and workforce initiatives, with a particular emphasis on supporting the behavioral health workforce, because we understood that even before the pandemic, our healthcare systems and workforce were experiencing crises, and our residents were confronting provider shortages, service reductions, ridiculously long waiting lists, and sometimes provider deserts. I come from Western Massachusetts, so we're very familiar with provider deserts. In Massachusetts, we understood that the pandemic, as it did with many systems, amplified and exaggerated our vulnerabilities. The pandemic urged immediate attention and action, and Massachusetts did respond. That's why we allocated $115 million to a loan repayment program for eligible behavioral health care workers through Mass Repay. We can all be proud of the success of that program. To date, it's offered over $270 million in awards to more than 6,100 direct care professionals across Massachusetts. The legislature also directed an additional $192 million to a behavioral health trust fund, the majority of which was later directed towards further bolstering the behavioral health workforce. And we continue to invest in healthcare providers. Just last week, the House included in its FY27 budget a $3 million loan forgiveness program for DMH behavioral health clinicians. As we discuss how to move the legislature and what we need, I almost feel like I should stop reading and just take questions, but I'm going to continue to read my remarks because we're at a crucial time, right? The House has put some funds into the budget, hasn't put all the funds that people need, hasn't put, in some areas has done very well, in some areas just a little short, but we still have time. There's about 3 weeks before the Senate votes on their budget. And there's this interplay that I'm sure you're aware of, a little dance that happens between the House and the Senate. And so it's still worthwhile to communicate to your senators what you want to see, because it's still important for them to express support for something that may end up in a conference in a couple of weeks. Because we are a state that still believes in science and in evidence-based practices, I'm proud to say we created the Behavioral Health Workforce Center to conduct research and make data-informed policy recommendations specifically designed to strengthen the behavioral health workforce in Massachusetts. And though I missed the morning's presentation on this, I'm looking forward to getting briefed by Gwen because I understand there's some things that happened in that research that we need to really pay attention to legislatively. I commend and appreciate the ongoing efforts of the center to monitor trends, identify challenges, and make recommendations on how we can continue to support behavioral health providers who deliver vital care in our communities. An ample workforce is a precondition to an expanded service infrastructure. We must continue to invest in and expand access to behavioral health care for residents, which means we must continue to support and sustain a robust, diverse behavioral health workforce. The two are inseparable. This session, I filed a bill, H223, which would set a schedule to fully eliminate the pay disparity between the salaries of human service workers employed by community-based service programs and state employees performing similar work. Too often, model budgets created by the Commonwealth for human service programs contain salaries sufficiently and significantly lower than what the state actually pays for similar positions. I feel like I'm in Western Massachusetts when I get an applause line for that. Community-based agencies experience this in very harmful ways, as you know. They hire and invest in their people, they train people, only to have them leave, understandably, for the same job at better pay with the state. That's ridiculous. We're cutting, I'm not sure what the analogy is here, but I know we're undermining ourselves. This has amplified the workforce crisis we are experiencing as community-based organizations struggle to recruit and retain skilled workers. We know that Massachusetts has a highly talented behavioral health workforce. However, these kinds of disparities are part of the reason why positions remain unfilled. This, in turn, leads to the closure of programs and ultimately the loss of much-needed services for Massachusetts residents. I also filed another bill, H2205, which would establish a new trust fund that is not time-limited or reliant on federal money to provide loan repayment to providers working to integrate behavioral health into primary care. This bill builds on the success of Mass Repay, which is no longer accepting applications, as some of you may know, for additional funding requests since ARPA funds have to be spent by the end of this year. We must continue beyond ARPA, and not only because of ARPA, to invest in this critical workforce to ensure that Massachusetts is not only the best place to receive an education, but also it's the best place to work and deliver high-quality care to people with both physical and behavioral health needs, and the best place to receive that care. I'm very grateful to be here today, and I want to thank you again for the invitation. I so appreciate all the work that you do to make sure that our workforce keeps up with the need and meets that need in our state. We have appreciated the opportunity to learn from all of you and consider additional ways we can partner to build and grow the behavioral health workforce and strengthen the behavioral health infrastructure as a result in the Commonwealth. Please reach out to me or to Gwen at the committee with ideas, thoughts, legislation that you think should be considered, or your support for an existing piece of legislation. We need to continue to partner together. Thank you so much.
Thank you, Chair Dom, for those thoughtful remarks. And we, of course, fully support your late arrival today in support of the Children's Mental Health Campaign and their event with the Ducks. So thank you for making the time to be here. Finally, I am so excited to introduce Martin Cohen, Vice Chair of the Health Policy Commission, to reflect on this morning's events and provide closing remarks. And in addition to reflecting on today and being here today, I just personally want to say thank you for your support and contributions to the Behavioral Health Workforce Center for this last year and a half and helping us to further develop and refine our research. We are truly grateful to have your wisdom and expertise on our side. Vice Chair Cohen served as President and CEO of the Metro West Health Foundation, a community health philanthropy serving at the Metro West area of Massachusetts, and has more than 30 years of experience working with federal and state policymakers to improve public mental health services. He previously served as a Deputy Assistant Secretary in the Massachusetts Executive Office of Health and Human Services, where he worked to expand access to behavioral health care for residents of the Commonwealth, and has served on the HPC board since 2015, where he advises the HPC team on our work to advance behavioral health care in Massachusetts. We're grateful to be able to work closely with Vice Chair Cohen, and please join me in welcoming HPC Vice Chair Martin Cohen.
I should say Martin Cohen, MSW. Let me start by thanking Amy, Matt, and the HPC Behavioral Health Workforce Center team for their work to shine a much-needed spotlight on clinician rates and behavioral health workforce issues. And to our panelists, Jemima, Ken, Leslie, thank you for sharing your insights and the work that you do every day to address these critical issues. I also want to thank Representative Dom for her thoughtful remarks, and to her colleagues in the Massachusetts legislature for recognizing the importance of this work through the creation and funding of the Behavioral Health Workforce Center. To wrap up today, I want to state what I think should be obvious to all of you. Behavioral health is essential health care. It is not a separate system. It is foundational to individual health and well-being, community stability, and economic productivity. Behavioral health is health. Mental health conditions affect 1 in 5 Massachusetts residents each year, touching every family, workplace, and community. What we also know, but what often goes unstated, is that behavioral health interventions work. With early screening, diagnosis, treatment, and support, recovery is possible, and people go on to lead productive and meaningful lives. We also know that untreated mental illness is costly. It drives higher rates of chronic disease, disability, homelessness, incarceration, and early mortality. And from a health policy and finance perspective, investing in mental health care reduces downstream healthcare costs in emergency department utilization and unnecessary hospitalizations. Behavioral health clinicians are the backbone of the system. They are not just service providers. They are problem solvers and lifelines, delivering interventions and treatments that help people recover. They are also the connective tissue working across fragmented systems to connect primary care providers, schools, hospitals, law enforcement, and social services. They are often the first and only point of contact for individuals navigating trauma, addiction, and severe mental illness. They translate complex symptoms into actionable treatment plans, helping people regain functioning, relationships, and most of all, hope. As was noted in the presentation earlier, the demand for behavioral health care has outpaced the workforce. Clinicians are carrying the weight of a strained system as rising rates of anxiety and depression, especially among young people, have created an unprecedented demand for care. Workforce shortages mean that clinicians are managing higher caseloads, more complex needs, and longer wait lists. These clinicians are essential to implementing new treatment models like CBHCs, mobile crisis teams, the recently opened Middlesex Restoration Center, and integrated behavioral health in primary care settings. Without a strong clinical workforce, policy reforms like the Roadmap for Behavioral Health that was mentioned several times today won't achieve their optimal impact. There's an old proverb that you get what you pay for, and we are getting what we pay for. Long wait times for an outpatient appointment, high emergency room boarding rates for those with behavioral health conditions, clinicians opting out of insurance panels for private pay, clinician burnout, and as we are seeing in Central Mass and other places, the closure of essential behavioral health services. We need to do better. We must strengthen our behavioral health system, and we can do that by investing in the people who deliver it. You've heard some very sound policy and financing recommendations included in this morning's presentation. Competitive compensation driven by fair payment rates, manageable caseloads, and supportive supervision are essential to clinician retention. We also need to invest in loan repayment, internship stipends, training pipelines, and career ladders in order to attract and build a sustainable workforce. Investing in clinicians is investing in better outcomes, stronger communities, and a healthier future. My final point is this. As Amy Rosenthal said this morning, in healthcare we often talk about the right care at the right time and in the right place. If we want a future where every resident of Massachusetts can access behavioral health care when they need it, we must value, support, and invest in the people and organizations that do this work. We can do that, but we need to do it together. I want to thank you all for joining us today. I hope you will continue to engage with the Health Policy Commission and the Behavioral Health Workforce Center and continue to lend your attention and focus to these important issues. Thanks for being here.
I can tell that everyone is waiting for the official permission to be able to stand up. Thank you all so much for being here today. We truly appreciate the support, and please stay in touch, reach out, follow up. We love hearing from you. So thank you so much, and have a great rest of your day.